Thanks very much to the organisers for inviting me to speak to you this afternoon. I'd like to make two comments before I start. One is that if I'd known I was going to be on video, I would have done something different with my hair. And please, can I have a copy of that, because that's the first nice thing Dr. Turner said to me in about 7 years. So this is a difficult subject, and these are difficult patients. So on your seat, there's a handout. I appreciate that not everybody, when you come to a talk, takes a great deal away from it. So I've put down in as clear a way I can my thoughts when it comes to the management of acute and chronic pain. And so the learning objectives really today stem from that handout. And I don't think you can begin to manage the patient with acute and chronic pain if you don't really understand normal pain processes yourself. A lot of the misunderstanding that comes when dealing with patients comes from what we believe about pain. And I really think that it is important to examine what you actually think about pain, what your prejudices are, what your thoughts are. What is it that you felt when you've been in pain and how you've managed that? So that's probably, if you take nothing away today, I'd like you to take away perhaps 5 minutes where you sit by yourself and ask yourself, okay, well, what is this pain business? How do I feel about it, and how do I interact with people? We'll talk about the very real differences between acute and chronic pain. These are two very, very, very different beasts. I always say to people, and in that handout I've made reference to diabetes as an example. All of us can have a high blood sugar. Too many sweets, too much booze. We can all transiently have a high blood sugar. In the same way that we can all have acute pain. But we don't all have diabetes. And that's the difference between acute and chronic pain. One is an experience everybody can have, and one is a separate entity that not everybody has. And if you begin to understand that that's what you're dealing with, it becomes a lot easier to manage patients. It's important to understand why pain becomes chronic, because there's a vast amount of research now about how to prevent that situation from happening. And as nurses and as doctors working within hospitals, we play a key role in managing the post-operative patient to prevent the progression to chronic pain. I'd like to introduce you to this idea of a biopsychosocial approach to the management of all disease and illness, but particularly with regards to the management of chronic pain. And then, it's 40 minutes. You're not going to leave here being an expert, despite how wonderful a teacher I am, according to Dr. Turner. But what I want you to leave here with is some preliminary thoughts, which together with that handout and your experience on the ward will eventually change your practice. So, there you are, half an hour of that. So, here's a patient, all of you, average patient in many ways, which I'm sure all of you would want to have in your operating theatre or, dare I say, bedroom. So the first point I'd like to make is, how does pain work? How does it happen? What do we do? What happens when we get injured? So at that level, this is what's happening. So I give you 5 minutes just to take that down, because that's very important. But really, all it demonstrates is that at a cellular level, when you injure yourself, a host of inflammatory mediators are released. They're released in response to tissue injury, and that tissue injury results in an activation of chemical signals into an electrical signal. So the first bit, transduction, which is in your handout, refers to the conversion of a chemical, thermal, or mechanical stimulus into an electrical stimulus. Okay? And it's important to note I've not started talking about pain. All I've explained to you is that the 3 ways you can damage the body, thermal, mechanical, and chemical, and they're converted into an electrical signal so the body knows what's happening. So that's the process of transduction. The next bit is transmission. So from the periphery, from David Beckham's Achilles, this happens very slowly in David Beckham, as opposed to normal people. So what happens is you get a transmission from your foot to your spinal cord and then onto your brain. And if you look at that picture, if you look at this, if you look at where my arrow is pointing, that's over the dorsal root ganglion. So if you look at that neuron, it's got a projection to the periphery and a projection to the spinal cord. And so really anything that happens in the periphery affects what happens in the spinal cord and vice versa. And that's key to trying to begin to understand how that system can evolve to give you persistent pain in the absence of any ongoing damage. Okay? So transmission is your next step after you've converted that signal. Now we're talking about pain. So there's an initial injury that all of us may have. There's transduction of that injury into an electrical stimulus. There's transmission of that stimulus to the spinal cord and brain. And it's when that stimulus gets to the brain that we perceive pain. So it's important to understand that pain is an amalgam of many, many factors. Your genetic background, your previous experience, your culture, your age, your health, your level of anxiety, depression. All of those factors will influence perception of pain. Because really what's happening on the floor now is he's damaged his Achilles. He understands that it's his Achilles because the information's reached his brain. But that look on his face is about the fact that he's not going to the World Cup, that his wife's going to be seriously unhappy with him. And it's the pain and the suffering he knows that Achilles injury will bring. So it's important to acknowledge that for all of our patients, whatever injury they have, whether it's a controlled trauma from an operation or if they're unwell in any way, will be interpreted in terms of their worldview, not ours. And that's a very important point to realize. And it's also important to realize that pain can be modulated and is modulated. There are pathways which descend from the brain and which ascend from the spinal cord, which can either facilitate the transmission of those impulses from the injured part or can in fact stop them or reduce them. And many of those factors aren't just about medication. It's about how the patient perceives the injury, how nice the nurse is to them, how well the doctor explains what's happened, how well they were consented at pre-op, what they were told in terms of managing expectations. All of these factors will play a role in ultimately how that pain is perceived and modulated. So that's, if you remember nothing else, and we're about 5 minutes in now, so I'll start to lose a third of you. Thank you for coming. That's key. Hopefully I've given you a few things to think about. Okay. So that's the first learning objective. And so I'd like to leave you with this picture at the end of that objective and just reflect on that for a minute, because this is really what pain is. It's not simple, and we're all different. And so you can do 5 lap choles, give each of them the same anesthetic and the same analgesia, and in recovery, one will be screaming, one will need an naloxone, one will, be absolutely fine, and 2 will be trying to chat up the recovery nurse because they're very pretty at Salford Royal. So very different reactions to the same stimulus. So that's acute pain. And that's fine. A lot of us understand acute pain, don't we? So you get an injury, you attend to that injury, the injury heals, the stimulus goes away, the signal stops being transduced and transmitted, you no longer feel that stimulus, and you get better and you get on with your life. But that doesn't always happen. So we talk about this continuum between acute and chronic pain. So the definition of chronic pain is pain which persists for more than 6 months. And the reason 6 months is used is because in that time, most injury heals. And so that's how we differentiate between acute and chronic pain. And remember I talked about that dorsal ganglion. Remember I had my arrow. So when that signal is transduced, nociceptors, which are harm-sensing receptors, are on the nerves. And 75% of the C ones, which are the dull, achy pain, are silent. They don't play any role in the transmission of that impulse. But if you have a persistent impulse or a genetic predisposition, you can start to recruit more of those C nociceptors. And what you essentially get is that field of stimulation winds up. So initially your injury was in a very discrete part, but soon the injury and the pain spreads in a further direction with regards to your initial injury. And what's happening there is that you're firing up more C fibers. And so, for example, if you treat post-operative pain poorly, patients will have a persistent barrage of input and they will recruit more and more of those fibers. And so that's one of the mechanisms at a peripheral level that leads to chronic pain. And the other is that you get central changes. So in this diagram, what you've got is the periphery, where your nociceptor is, and you've got the spinal cord. And what you can see is the development of hyperalgesia and allodynia. So sometimes when you touch the skin around an area where somebody has been injured, it's painful to light touch. Now we all know that light touch isn't painful. But what you find is in these patients it is, and that's because there's cross-wiring in the spinal cord of sensation which comes from the periphery. So normal fibers that transmit light touch now attach to the fibers that transmit pain. So light touch is perceived as pain, and painful stimuli are perceived as being more painful. And so often patients with acute-on-chronic pain who have this wound-up system respond very badly to having an operation, because you've already turned up the volume on the radio of pain, and when you add another insult, it just gets wound up even louder. So that's essentially what's happening in these patients. We also know that at the level of the brain there are changes. So this is a functional magnetic resonance image of a patient who has chronic back pain, and that's their brain. And effectively, patients with chronic pain, long-standing chronic pain, have changes in their brains. So we know, for example, that if you have repeated episodes of acute low back pain, what tends to happen over time is that new connections are made within your brain. So even though there's no ongoing damage in your spine, because you've made those brain connections, those sensations of pain persist. We actually do know as well that patients with chronic pain have atrophy of their grey matter. And so actually cognitively, while they may appear biologically at the age of 50, cognitively these patients have lost so much brain material that they are actually intellectually older. And so often they do struggle to comprehend. I mean, that's not made any better by the fact that they're often on quite high dose opiates, which further exacerbate that situation. So this is the evidence of why acute becomes chronic and why chronic pain is maintained. Peripheral sensitization, central sensitization, and actual changes within the brain. So in the same way that you would describe a diabetic as having changes in their insulin tolerance, in their glycemic indexes, in the pathology within their pancreas, chronic pain is a real condition. Because often when people have pain beyond what we expect them to have, the first thing we would often say, not everybody in this room, is that they're malingering or they're putting on or they're being over-emotional. So, and everybody is different. So if you look at this slide, it's a slide of what predicts disability and pain. So if you look into those two groups, you could probably put yourself into one of those two groups in terms of the way you deal with life situations. So for example, catastrophizing. I know when Alison was younger, she would, for example, if she broke a nail, would probably say, oh my God, I've broken a nail, I'm not going to meet the man of my dreams, I'm not going to have my 2 children and have a lovely life. So that's catastrophizing. It's when you take a simple event and you extrapolate a very negative future. And a lot of our patients often do that. That factor is a negative predictor for actually coping successfully with pain. And it is a predictor when you have chronic pain of becoming disabled with it. Whereas if you're like Dr. Turner, who's optimistic and joyful and mindful and actively copes all the time, very unlikely to develop chronic pain, likely to give other people chronic pain. It's important to also acknowledge that many of these concepts are not just spurious. They are actually rooted in science. So, for example, being optimistic has been shown to predict and to be able to lower pain. So they took a group of university students and they asked them to imagine their ideal self. So for me, it would be 6'2", 180 pounds, etc. And they then applied a cold stimulus to them. And they found that when they did that and asked them to visualize the ideal self, they had lower pain scores. Whereas when they asked them to imagine a negative view of themselves, they had higher pain scores. So it's very hard to do a QI project on optimism on your ward, but being optimistic is a positive, is positive in terms of coping with pain. So let's get back to David. So David gets injured and he's in pain. So now this can go one of two ways. He gets injured, he goes off to, I think he went to Finland, which upset my wife. She's a foot and ankle surgeon. She's very angry that he didn't get it repaired here. And, he gets back and Victoria's very nice to him and he, gets regular Achilles tendon massages. Though I suspect her fingers are quite bony, so that probably wouldn't be very nice. Anyway, he gets adequate analgesia. His nurse is very nice to him. Surprise, surprise. And he gets better, rehabilitates, gets on with his life. But actually, it can go another way. So he gets injured, he has pain, and he decides that this is the end. He's going the way of George Best now. So he stops moving, he gets muscle spasm, he doesn't understand that it will heal, he starts avoiding activity, doesn't play with his children, he gets fat. There's something I'd like to see. He doesn't go back to the LA Galaxies, he doesn't work anymore, he stops going around to his mate Tom's house, he doesn't do much activity with his kids, he becomes quite helpless. He focuses on this Achilles tendon, it becomes his whole world. He gets angry. His surgeon in Finland is no good, so his Achilles doesn't get any better. His family start giving up on him. He gets more distressed because he gets another opinion and he feels equally unreassured by that opinion. He loses his big house. He has to end up living somewhere else. And ultimately, you end up with somebody who's lost everything. So you go from being David Beckham to having lost everything that you valued. And often with our chronic pain patients, that's what's happened to them. And it's happened over a period of time. And as a result of that happening, they are less able to cope, particularly when they get admitted to hospital for operations. So that's the kind of patient that you have. If I allude again to the diabetes example, it's the same as the diabetic who has renal impairment, has diabetic peripheral neuropathy, has ischemic heart disease, is not particularly compliant with their medication. So when they come to hospital, they present a significant challenge if they're coming for an exacerbation of their diabetes, or alternatively, if they're being admitted for surgery. So it's a sort of similar kind of patient. So just a little more about chronic pain. So this is a classification of the things you might come across. So broadly, we divide chronic pain into three kinds. So there's neuropathic, which is disease or injury of a nerve. Fairly straightforward. It can either be central or peripheral because the nervous system is divided into two. So it can be central, multiple sclerosis, central post-stroke pain, or peripheral, people with sciatica, people who've got diabetic peripheral neuropathy, trigeminal neuralgia. These are examples of neuropathic pain. Nociceptive pain, where there's an ongoing stimulus sometimes which can flare up, osteoarthritis, rheumatoid arthritis, colitis. And then there's a group of what we call generalized pain, where the problem and the disorder is that of central pain processing. So these are patients with fibromyalgia, irritable bowel, musculoskeletal pain. So we think there the problem is that the way these patients process sensations from the periphery differs from you and I. So I said at the beginning that I would talk about the biopsychosocial model of pain, and that is in your handout, the one that's typewritten, not the slide handout. So it's useful to think of a disease in terms of the biological, the psychological, and social factors. And if we move away from pain to something which you're perhaps more familiar with, like diabetes, for example. So biologically, the definition of diabetes is a relative or absolute lack of insulin, and it gets treated with insulin. Psychological factors, however, will impact on whether that patient manages that disease successfully. So how educated they are, what they think about their disease, what their long-term goals are, and the social or environmental factors, i.e. do they have a supportive environment, are they motivated to be better? So unless you address all of those three factors, you won't actually have a compliant patient who's well managed. And the same applies to chronic pain, because chronic pain affects every aspect of somebody's life and is a very integrated, the management needs to be integrated, because they have physical deconditioning, so there's a functional problem here. They have psychological morbidity because they're depressed and they're anxious, they don't sleep, they have no self-esteem because all they are is an amalgam of their pain. There are social consequences, and they are socioeconomic. So unless you address all of that in the management of chronic pain, you won't actually move anybody forward, improve their quality of life. And the point I'm trying to make to this audience is that this is the complexity of the individual that you're dealing with. So just upping their morphine, just changing their gabapentin, and not actually dealing with them in a particular way is not going to move you forward. And just again to reinforce the point about how chronic pain evolves, a simple example would be you get chronic back pain and you think, okay, well, I could end up paralyzed if I'm not careful. You get distressed, you get frightened, you take to your bed, you withdraw from society, your family overprotect and encourage rest, and they end up as somebody with high distress and disability. An alternative is that they have the same problem, they have a different way of viewing it, their family encourage them, and they end up continuing to function despite pain. So those are the sort of two scenarios. And your patients with pain, chronic pain, often present potentially on a spectrum of those who are well managed and those who are very poorly managed, like your diabetics. There are some who are rigorous about their insulin, rigorous about managing their diet, and then there are those who are very poorly compliant. And so despite somebody having chronic pain, to you, on the ward, they might present in a very different way. And it's important to make that assessment when you see them. So let's get to the meat of it, and I'm nearly done. So what do you do when you encounter these patients? You need to plan. And in your handout, I've elaborated on this, but they need to be identified preoperatively. Ideally, you don't want to operate on patients with chronic pain. There's some good work that demonstrates that people who have chronic pain and depression, if you do a total knee replacement on them, will have significant pain following the knee replacement, despite a technically successful replacement. So, sometimes, and I try to, whenever I give a talk to surgeons, to make this point, is you have to choose your patient very wisely, because there will be people who won't benefit. If you're fortunate, and we've got quite a big inpatient pain service, we are the Manchester United of inpatient pain services. But you might have access to somebody who does chronic pain, and it's useful to perhaps get their input about what they think should happen with this patient. You need a plan for post-op analgesia, because if you don't have a plan, you will struggle. You need to share whatever you're going to do with the patient. So no decision about me without me. And that's really important, because I explained to you earlier about the many psychological factors which play a significant role in both the development of chronic pain and the maintenance of chronic pain. These are vulnerable people, and unless you talk to them, often when I go on a ward round to see the difficult patient, all I do is talk to them. I like to think of myself as the chronic pain whisperer. Because actually that's sometimes all they need. They just need you to engage with them, to tell them that you're on their side, and that but boundary them at the same time. Putting boundaries around people is important. So one of the things I'll often say is, if 0 is no pain, and 10 is the worst pain you've ever had, I can do 4 for you. 4 is the best I can do for you. I do this with my wife. If there's a 0-carat diamond and a 10-carat diamond, I can do 1.5. That's all I'll ever be able to do. She's not accepted it, and we're in the process of negotiating. But it's the same with these patients. You need to have shared decision-making. You need a documented plan, and you need to stick to it. So that's the patient who comes in for surgery. The patient who comes in with a flare-up of their chronic pain is even harder. There's no focus here. And often the patient who comes in for a flare-up of their chronic pain is no different from the patient who comes in with poorly managed diabetes. At their baseline, they're in chaos, and at their baseline, they don't understand their disease. At their baseline, chronic pain patients who get admitted with a flare-up have often not been worked up through a pain service. They don't understand their pain. They have misattributions about the nature of their pain. They don't understand why their pain persists. They don't understand why some doctor's doing an MRI scan and another doctor thinks it's not necessary. They don't understand why they're on an antidepressant. Do you think I'm depressed, doctor? So these patients often present a significant challenge to the nurses who are tearing their hair out because they've got one team who comes on and says one thing and another team who comes on to say another. And really the key with these patients is clear communication about treatment goals. Why are we investigating you? What are the limits of our investigations? What can we do for you? What can't we do for you? What do you want us to do for you? Their concerns and their expectations, ideas are crucial. If you can and you have access to it, an inpatient pain service can spend more time with the patient than you potentially can. You need close collaboration between teams. Because if you don't, as is indicated in that picture there, you'll be misaligned and you'll never get anywhere with this patient. I thought I'd talk a little bit about drugs, not very much, just to mention the different groups. So at the beginning, I talked about changes in the spinal cord and changes in the brain, and then changes at the periphery. So with chronic pain, because you've got a nervous system which is essentially changed, the drugs are different. So we use different classes of drugs to modulate the nervous system. So we use anticonvulsants, drugs like ketamine, opioids, antidepressants. And we use these drugs because essentially you're trying to change the way the nervous system transmits impulses. And you're trying to activate those descending systems which stop pain transmission. So once you move into the realm of chronic pain, the kinds of drugs you use are different. And it is important that you try to develop systems within your hospital that incorporate these therapeutic strategies within your biopsychosocial framework. And that's done from pre-op through to the intra-op, post-op, and the recovery phase. So you need a joined-up plan. So these are my take-home messages. Nociception is not pain, it's the detection of harm. Transduction is the conversion of a chemical, electrical, or thermal signal into an electrical signal that gets transmitted to your brain, and pain is perceived there, and that signal can be modulated. You can change the nervous system through central and peripheral sensitization and develop chronic pain. Acute pain is not chronic pain. The biopsychosocial approach needs to be adopted in everything we do, but particularly with regards to these patients. And chronic pain can't be cured, but it doesn't imply ongoing harm. Thank you.
Any questions?
I've either been very clear or extremely unclear. I like to think I've been extremely clear.
You have told that there is a chronic pain. If it is not treated effectively, then it might cause the brain atrophy, every years. Is there any studies, which shows, if we are continuing these adjuvants, along with the pain analgesics, it does reduce that atrophy?
I'm not aware of any prospective studies that have followed chronic pain patients up for a long time, which the question is about whether or not brain atrophy can be retarded if you treat chronic pain appropriately, but I'm not aware of any prospective long-term studies. Because of course that would be potentially difficult to do because, for example, I suppose you'd have to look at two different populations, one with and without, but I'm not aware of any studies which show you can retard that. And
it is always advisable to continue these medicines like neuropathic, controlling the neuropathic pains, or generalized pain. We should continue these throughout the rest of the life. That is, to say, if it is beneficial.
Yeah, I think again, I go back to my diabetic analogy. You wouldn't stop somebody's diabetic medication at some point. I think if you've got chronic pain, that needs to be treated because the consequences of untreated chronic pain are progressive disability. Your aim isn't the pain itself or the pain intensity. What your aim is to treat the patient in order that they can do the things that they need to do in their lives. So your outcome is an improvement in function rather than a focus on pain intensity.
All right.
In the same way that when you treat acute pain these days, your outcome measure isn't really on pain intensity, it's trying to get them to get up, get out of bed, cough and breathe deeply. Pain intensity is a very small measure in measuring pain outcomes.
Thank you.
As a service, do you get to know about the chronic pain patients for the acute on chronic?
Yeah.
Do you find that you get the referrals
Yes.
pre?
So,
I don't think we do.
There's an alert system which is generated from pre-op. So there are 4 questions that we ask, or that is asked in pre-op. Are you on chronic opioids? Have you had previous difficulty managing pain within hospital? Are you anxious? And are you on chronic are you on chronic opioids? So and addiction. So if those questions are positive, then a referral gets triggered to the pain service. When that patient is admitted, there's an alert system on our electronic patient record, which...
And Dr. Megan will be talking about that a bit more in his own talk.
Right, okay. Thank you.
Spoiler alert. But one of the outcomes has been that there's a reduction in out-of-hours calls to the on-call anaesthetist. So when you do your on-call as an anaesthetist at Salford, you very seldom will be called to manage difficult pain at night.
Or is this any advancement in the pain management other than these pharmacological measures?
So apart from drugs,
Yeah.
you mean in terms of optimizing perioperative pain? Well, in an ideal world, and some people have done this, is they've done preoperative hypnotherapy, people have had cognitive behavioral therapy, anxiety management, pre-education, which has led to an improvement in perioperative outcomes.
That's right. I'm asking you.
Yeah.
In your experience, do they help?
In my experience, we don't do them. We do educate people in pre-op, but that's the limit of what we do. It's quite hard to implement. It's quite labor intensive, that sort of thing. So I don't have any experience, but from what I've read, people have made significant improvements in bed days and stays in hospital by implementing quite simple educational tools. Sort of telling people what to expect, telling them how they'll feel, giving them written material. Those aspects have improved patient outcomes. You need to change the conversation. You need to change the conversation from people believing that they're coming into an uncontrolled situation and they need to respond as an animal does in the wild in a fight and flight way. People need to understand, I suppose, that this is a controlled trauma that they're consenting to, that the sensations that are being transmitted to their brain are perfectly normal because they've had an operation, but that they're safe and okay to move. And I think that if you change that view, you can make great strides, much more so than you can with new drugs, because there aren't any.